Good afternoon and welcome to Frankly Speaking About Cancer with the Cancer Support Community. Your host is Kim Tibaldo, President and CEO of the Cancer Support Community. This hour is designed to inspire, inform, and to help you live better with cancer. Now, here's your host, Kim Tibaldo.
Welcome to Frankly Speaking About Cancer, an internet radio show that focuses on informing and inspiring people to live well with cancer. I'm your host, Kim Tibaldo, CEO of the Cancer Support Community. For more than 35 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help individuals manage the realities of this disruptive disease and get back to a new normal. Whether accessing our free services in person, at one of our 175 locations, online, or over our toll-free helpline, you're getting a team of licensed professionals providing patient navigation, financial counseling, genetic counseling, pediatric support, and more. Well, today's episode is part of our special series, Spotlight on Coronavirus. All of us at the Cancer Support Community are committed to getting you the information that you tell us you need as together we face the impact of the spread of the coronavirus. In the last week, our Research and Training Institute launched a survey asking cancer patients and their caregivers to identify their concerns. And we'll be addressing them today with two wonderful doctors in our episode. I just want to mention, as usual, this information today is not meant as medical advice, and it is not meant to replace information or guidance from your own physician and medical team. Before we get started, I want to share a quote from American physicist Richard Feynman. I think it frames our conversation today really well because there's still so much we don't know and are learning about the coronavirus, COVID-19. He said, quote, "I think that when we know that we actually do live in uncertainty, then we ought to admit it. It is of great value to realize that we do not know the answers to different questions. This attitude of mind, this attitude of uncertainty, is vital to the scientist." We're fortunate to have with us today two truly knowledgeable doctors who are going to share their insights with us as together we navigate these challenging times. Returning to the show is Dr. Mary Jennifer Markham, and joining us for the first time is Dr. William Dahut. Dr. Dahut is the Scientific Director for Clinical Research at the National Cancer Institute Center for Cancer Research. In this role, Dr. Dahut oversees and assures the quality of medical care delivered to patients participating in CCR clinical trials. Dr. Dahut is also the Section Chief of the Clinical Translational Prostate Cancer Research Program, which emphasizes new approaches to the treatment, diagnosis, and prognostic evaluation of prostate cancer with the goal to increase the precision in which therapeutic decisions are made for patients with primary and metastatic prostate cancer. In this research, his mission is to improve therapy for men with advanced prostate cancer. Welcome to the show, Dr. Dahut.
Thank you very much. Really an honor to be on.
Dr. Mary Jennifer Markham is Associate Professor and Interim Chief of the Division of Hematology and Oncology at the University of Florida. She is Associate Director for Medical Affairs for the University of Florida Health Cancer Center, and she is a medical oncologist specializing in gynecologic cancers. She is chair of the ASCO Cancer Communications Committee and is the social media editor for the Journal of Clinical Oncology and the Journal of the National Cancer Institute. It's great to have you back, Dr. Markham.
Thanks so much for having me back, Kim. It's a pleasure.
I'm going to start with you, Dr. Markham. Although many of our listeners may have heard this a few times already, I always like to level set, and I think it's worth taking a step back and reviewing what coronavirus is, its relationship to COVID-19, and why it has set off this, real worldwide concern, especially as most states have now issued stay-at-home orders. So let's start with the basics.
Sure. So coronavirus, the one that we are talking about, is the virus that causes the disease, COVID-19. And this is a novel coronavirus that was discovered in China in December of 2019. Coronaviruses are a family of viruses, and some of the more common ones cause things like the common cold. They cause respiratory illnesses. This coronavirus, though, is causing a more, what seems to be perhaps a more severe respiratory illness that is very transmissible. And this is why many of our states and counties across the country, and actually countries, period, or plural, have issued shelter-in-place orders.
Got it. Dr. Markham, we've seen images of people lining up to be tested at hospitals. Some are being tested at home, I hear, even being tested at drive-thrus. If someone does get tested, what should they expect to experience?
So the test itself probably doesn't take very long compared to the amount of time people may wait to actually get tested. The test probably takes about 5 minutes. It usually involves using a swab that may look similar to a Q-tip that is inserted into the nose. So it's a nasal swab. It can also be done by a healthcare professional in the back of the throat. And for people who unfortunately may be in the hospital and have be on a ventilator, which is a breathing machine, sometimes we are actually getting lung secretions to do the test on. But for an average person in the community who thinks they may have symptoms and whose doctor advises them to get tested, it should be a very quick procedure. I haven't had it myself. I am told that it's not the most pleasant thing if you imagine a Q-tip going into the back of your nose, but unfortunately the secretions in the back and a good sample is actually what's necessary in order to get a good test.
I see. And what about these new blood tests that we're hearing about? What are those?
So I think that's probably referring to the antibody testing. When your body is infected with anything, with a bacteria or a virus, your body creates antibodies. That's your immune system's response to the infection. And so what we believe happens in this virus is that people who have been exposed or have been infected or are currently infected may have detectable antibodies to the virus in their blood. There's not currently an approved test for this, but I think they are coming, and we're trying to figure out, we as a medical community, how best to implement these. But right now, I think in most communities, the nasal swab is really the primary test that's being done. Got it.
Dr. Dahut, in our last show, we sort of talked about, cancer patients, if they're concerned that they have the coronavirus, if they're in active treatment for cancer, really they should be calling their oncologist to talk about their concerns. Would you agree with that? And what if we're talking about somebody who's maybe quite a bit out from their treatment? Who should be their first phone call? We're trying to give our listeners some advice on that.
Kim, those are really important questions. And I think what's really struck me is that there's never been a time in oncology when the care needs to be as personalized as it is right now. We've talked a lot about precision medicine and other aspects of treating cancer patients, but at this time, really you need a caregiver who understands your disease and understands your treatment and actually understands your family situation in a way that's critically important. I think my general advice for this question is that a patient should call whoever they usually would call if they're going to be sick. So if a patient is under active treatment and most of their communications are with their oncologist and they think they may have coronavirus, call your oncologist. But generally, if you're now, years out from your treatment, if you're one of my prostate patients who are now 6, 8, 10 years out, and you have symptoms and most interactions with your primary care doctor, call your primary care doctor first, because he or she is probably the one who knows you best.
Good. That's good advice. Dr. Dahut, I also want to hear your thoughts about a question that's been coming up a lot. Most patients and survivors we've spoken to are really being very cautious about how they navigate through the world, taking all of this advice very, very seriously. But folks want to know, are there particular groups of cancer patients who should be extra cautious? We hear this term immunocompromised. Are there particular groups of patients, cancer patients, that are especially immunocompromised? Maybe stem cell transplant patients or those who are on active chemotherapy? What can you tell us about that?
So again, another great question, Kim. I think when we think again of a cancer patient, it's very important, firstly, to personalize them, and first think about how they fit into the general population. So if you're a cancer patient who is already at higher risk for having complications from coronavirus, if you're elderly, probably if you're male, if you're someone who has diabetes, heart disease, or you have hypertension, then I think you have to have extra caution. We do know from statistics available that cancer patients are more likely to contact coronavirus and are more likely to have serious complications from it. Most of the data we see have not really broken down by individual cancer patients and how they're treated, but it does make sense to us that if you're a patient who's on a treatment that's fairly intensive, bone marrow transplant, leukemia, high-dose chemotherapy, I think you should be extra cautious. Or if you have a cancer that puts you at higher risk, something like multiple myeloma or leukemias or other diseases which we know impacts your ability to fight infections, you then, again, need to be aware that you're in a higher risk group. Some other things that you might not be aware, a lot of cancer treatments have high-dose steroids, high-dose prednisone, and those can actually block your T cells, which are the cells which often can fight infections. So those patients need to be cautious. Now, not all chemotherapies are the same. There are some chemotherapies like the drug called Cytoxan or the drug called fludarabine, which we know makes patients particularly immunosuppressive. But there are others, such as the drug called docetaxel, which, while it would put you at somewhat higher risk, is not nearly as immunosuppressive. So really, it's really important to talk to your doctor about your treatment, and maybe even talk to your doctor, are there other chemotherapy agents which you could switch for yours, which would put you at lower risk?
That's great advice. And I know that we talk a lot in cancer care about shared decision-making and that patient-physician communication. Dr. Dahut, it sounds like now it's more important than ever to engage in that kind of communication.
Totally agree.
Yeah. A practical question, Dr. Dahut, that we're getting from patients, maybe, again, patients who are in treatment. It's about going out and getting necessities like groceries at the market or medications at the pharmacies. We've had some folks call in and say, I do have a caregiver in the home. He or she can go out and get those things for me. What do I need to do when those things are brought back into the home? Or I'm alone. I don't have a caregiver. I don't have somebody to get these things. I do have to venture out. So what precautions should I be taking?
Well, I think it's really important to follow the CDC guidelines, and particularly when one reflects on one's own particular risks. I think in general, one should only go out if it's absolutely essential. And I think that's particularly important if it's a cancer patient. If there's someone else who can go out to the grocery store or pick up medications for you or pick up your scans from somewhere, please, if at all possible, do that. We know that's not always possible. Sometimes folks are in a situation where there's not someone who can help them out. So use precautions. See if you can do delivery. I mean, a lot of pharmacies are doing that now. Grocery stores are doing that. Make sure when you go out, consider wearing a mask because there may be some protection available. Wash your hands carefully and use social distancing at all times. But use your common sense with this. I mean, it's really important that if you're a cancer patient, you do everything possible to try to avoid an infection.
Great. Dr. Markham, there have been several news stories in which patients have spoken about not starting treatment for their cancer, delaying treatment, postponing surgeries. Some are having their treatment stopped or delayed mid-course. I want to dive into this a little bit because there are a lot of scenarios that could happen, and these things are causing tremendous anxiety for patients. We're getting a lot of phone calls on this subject lately. So, Dr. Markham, what should patients consider as they think about starting or stopping treatment for their cancer during this time, or having a surgery delayed? How does a patient frame this and really manage that anxiety?
So I do think it's really important for your listeners to know that they don't have to make these decisions themselves, and they really shouldn't. They should be having these conversations with the surgeon or with the oncologist or radiation oncologist who's recommending treatment, because there is no one right answer, and that's the tricky piece. Dr. Dahut talked about personalized medicine, and this really is another example of how the decision-making is going to be quite personalized depending on that individual patient scenario. So, for example, some patients may be living with cancer. Maybe it's a metastatic cancer and they're on treatments and on breaks and those alternate. Well, maybe it's safe for that individual patient to postpone treatment for a couple of months based on the pace of their cancer, or maybe because their cancer is currently stable. For someone else, though, maybe it's actually more important to treat the cancer despite the coronavirus. And I think that is only something that can be decided between the oncologist and the patient. Surgery, I'm glad you brought that up. There's been a lot in the media about hospitals and surgeons delaying or canceling elective surgeries. So in general, cancer surgeries are not really considered elective. Some things may be, in the sense that they are not urgent or emergent and must be done in the next week. But again, that really will require some conversation with a surgeon. And I'll just give you an example. We have at my institution a breast cancer surgeon and a breast cancer team that includes oncology and radiation oncology. And for some women, they are opting to change the sequence of treatment. So maybe surgery gets delayed a little bit, but they start with some medical therapy first. So there are ways to work around it for the patient so that the individual patient is not placed in excess risk of harm, either due to the cancer treatment or due to the coronavirus.
Got it. So let's say, Dr. Markham, a patient is to go ahead with their chemo, is to go ahead with their surgery. They're concerned, as you can imagine, about whether it's safe or not to go to the hospital and to the treatment facility. Generally speaking, what steps are being taken to keep patients safe when they are going in for their care?
So that it is a valid concern, and I think we all do need to think twice about whether we need to keep an appointment or whether it can be postponed or delayed. And so that is actually what a lot of cancer centers and cancer treatment facilities are doing right now, is they are reviewing patient lists and trying to figure out if this is somebody who maybe can have a delayed visit or maybe a visit by telemedicine. And some people can. If there are patients who are perhaps on oral medications that don't need to come in for an intravenous and IV infusion of treatment, those folks may be actually able to do a visit by telemedicine, which is essentially by phone call or by FaceTime or Zoom type meeting with their doctor. Now, some people obviously do need to come into the doctor's office or to the infusion center or the radiation oncology suite. And so what many places have done, I would probably say most, has instituted a couple of things. One is a visitor policy. Many places now are restricting visitors to perhaps one person and some even maybe no additional visitors. This helps the healthcare facility maintain a distance between patients and between staff and visitors. So we know that the 6 feet rule for physical distancing is important to maintain. It's very hard to maintain if you've got a crowded waiting room with visitors. It's easier if you can limit the visitors, and it keeps everybody safer. And then screening. So a lot of patients and visitors are being screened at the front door of the hospital or the clinic for symptoms of COVID or for a history of exposure. And if that's happening, then those folks are actually being recommended to have treatment or to be tested for COVID. And it's a way to keep everybody safe within the building and to keep that particular person safe. And of course, simple things like very good cleaning, disinfecting within the hospital and within the infusion center, using proper personal protective equipment or PPE, which really refers to masks and gowns. And I think those are all important things that are being done to keep people safe.
If you're just joining us, this is Frankly Speaking About Cancer. This is part of our series Spotlight on coronavirus. We're having a really great Q&A with Dr. Bill Dahut. He's the Scientific Director for Clinical Research at the National Cancer Institute Center for Cancer Research, and Dr. Mary Jennifer Markham. She's Associate Professor and Interim Chief of the Division of Hematology and Oncology at the University of Florida. Dr. Dahut, I was asked a good question by someone recently. I know that different cancer patients are treated in different settings. Many of them are treated in a community hospital or a community cancer center. Many are treated in some of the larger academic cancer centers. What difference does that make in this current coronavirus situation, if any?
So, Kim, I think the most important thing for the patient is that you need 3 things. You need somebody who knows the patient's pace of disease, knows the patient's other underlying medical conditions, and probably knows the patient's social situation. Then you know somebody who truly understands the disease itself in a way that they can make those tough decisions that Dr. Markham talked about who should potentially hold treatment, who can maybe even skip a dose. And finally, particularly now, you need somebody that can be easily reached when there's a question or concern in a COVID-19 situation. So, I don't think care is nearly as siloed as it might have been. And we have, very skilled physicians in every clinical setting. So, and oftentimes we'll see team approaches where patients may be on a clinical trial, in a large city at an academic center, but get some of the care at home. So as long as your team can really provide you expertise on the disease, an understanding of the patient, and an ability to reach somebody rapidly in an emergency, then I think you can be successful.
Terrific. Dr. Dahut, let's keep going. I know that even under normal circumstances, a cancer patient might go to the emergency room because of a symptom or a complication, a fever, other things happening that may be related to their treatment. Certainly with news reports indicating that some emergency rooms are overwhelmed, are at capacity. How should a patient proceed if they have some symptoms or complications or side effects that are really concerning to them?
Kim, again, a great question. Sadly, due to their illness or due to the treatment, many cancer patients will suffer complications, some which are very serious. Most cancer centers have guidelines about when one should go to emergency room, either on their web page or maybe oftentimes even printed that's given out by the treatment nurses. I think under this particular situation, I think what makes sense for patients is when they're seeing their nurses or seeing their physicians to really start going through those questions again before they need to go to the emergency room. There are certain things that we know it's very important that a cancer patient is in the hospital within an hour. We know if somebody has a very low white blood cell count and develops a high fever, antibiotics within an hour are crucial. So, of course, you need to go someplace where you get antibiotics. But sometimes there's some judgment in these. So sit down with your treatment nurse, your physician, your nurse practitioner, business assistant, and sort of go through the guidelines. If I have this, who should I do? Should I go to the emergency room or call somebody? And I think that's really the way you'll be best prepared.
Good. And so I would say that, so part of what you're saying is, perhaps also if you are, folks who are listening, if you're in active treatment and you are connecting on different things with your oncology team, maybe have some of those questions on the ready. Even if you're feeling fine, maybe have that little bit of that contingency plan in place. Hey, doc, hey, nurse, if this happens, what do you recommend I do? If that happens, what do you recommend I do? Maybe it's a good time if you're chatting with your doctor about care to, would you agree, Dr. Dahut, to maybe
I think that's
particularly
important because then you'll be talking to somebody who really knows you. Oftentimes, if you call somebody after hours, you'll get somebody who, may be covering for the practice or maybe, a house staff member. So I think if you sort of, as best work out that game plan with someone who knows you and your cancer the best, I think that puts you in the safest hands.
Good. Dr. Markham, we know that sometimes patients have to travel long distances to get their treatment. They may be going to a specialized facility. They may not have the care in their area. If the decision is to proceed with treatment, the patient needs to go on that journey for their care. What precautions should the patient take on that journey? How do they prepare for that? And what also does the caregiver accompanying them need to know?
Sure, and we know there's a lot of areas in the country that are rural, and sometimes people do have to travel a distance to get to their oncologist or their cancer care team. I think that what I would, number one, say is people shouldn't panic if they do have to travel to see their doctor and have treatment. Common sense really goes a long way here, and just being really concerned about your own personal protection. So I think my personal advice would be, you're not going to be able to wash your hands in the car. So be sure to pack some hand sanitizer to take with you. If you happen to have gloves, that's perfectly acceptable. I'm a big fan of using paper towels or tissues to open a door handle and then throwing that right in the trash. So maybe come prepared with a box of tissues. I think minimizing contact with more people than you really need to be around is important. So if you can perhaps pack your own food, pack your own lunch if you know you're going to be away during a mealtime. That's a great way to not risk any exposure to unnecessary people. I think many restaurants are doing drive-through and things like that still. But I think if you are a patient who has cancer and you're going through cancer treatment, minimizing exposure is important, especially if there are ways to do it. I think it is worth probably checking with the cancer care team on options for remaining closer to home. I know that some cancer centers are really great at working with local oncologists or local cancer treatment centers, and maybe part of the treatment can be transitioned to a local oncologist to save some driving time and save some travel time. I do think, though, number one is don't panic. If you need it for your treatment and your doctor has said, yes, we really need to get you here for this treatment, they will take care of you.
Good advice. Dr. Dahut, I want to stay on the subject of caregivers for a moment. Many caregivers have reached out to us concerned as a caregiver. What do I do to help keep my patient safe, but my loved one safe at home? I am the one as the caregiver going out to the pharmacy, going out to the supermarket and keeping the trains moving, so to speak. So what can we tell our caregivers to give them some assurance that we recognize that they still have to fulfill these tasks, but maybe they could take some extra precautions?
Yeah, but another great question, Kim, and I think it's a lot of the same advice that Dr. Markham just gave when we talk about patients traveling to visit. So it's very important for the patient to remain healthy, and in the same way, it's very important, if possible, for the caregiver to remain healthy. So the general guidelines, limiting exposure, you get medications delivered, it makes sense. And also, it's really important, I think, at this point, for the caregiver to be perhaps the advocate for the patient in conversations with the team. Again, some of the points that Dr. Markham brought up, and some things that we're doing on some of our trials is, can some of the care be given closer to home? Do I actually need blood drawn every single week, or can I spread that out? How often do I need to do my restaging scan? So sometimes, the patient is reluctant to ask those questions because of sort of the delicate relationship between the patient and provider. But this is an opportunity for the caregiver to really be an advocate for the patient in this during the COVID-19. Obviously, the things we've talked about earlier, limiting contact, hand washing, mask if you're in a public place. I do like the great suggestion about having paper towels or tissues available to open and close doors quickly. So, I think it's important that sort of common sense things are being done. But again, being an advocate in any conversation, we don't want to compromise cancer care, but we certainly want to do whatever we can be done to minimize the risk to the patient, period.
Yeah, good advice, Dr. Dahut. So let's talk about those masks for a minute. We know now there's a recommendation that we should be wearing some kind of homemade masks if we're, out and about on errands. We've seen all sorts of masks. We've seen someone using a ski mask, someone wearing a motorcycle helmet. My friend's mother went to the store the other day. That she lives in Florida, and she went with her snorkeling goggles to the market the other day. Which I said, Lorelei, I wish I had a picture of that one. That would be she had on a mask and goggles and her gloves at the store. But what's the difference, Dr. Dahut, between the masks you might wear when painting, working on home carpentry, and then these N95 masks that are mentioned in the reports, and what do you recommend to the average person about these masks?
So we're all talking about masks. So I think this is a great question, and I think it's very different if you're wearing a mask as a healthcare provider. And as you mentioned, there really are two masks that tend to be worn inside the clinics or the hospitals. Now, there's a really significant difference between the surgical mask and the N95. And actually, many physicians really had never worn an N95 or often not even seen an N95, so much less the lay population. A couple basic things. The surgical masks are approved by the FDA, while the requirements for the N95 are actually approved by a higher level approval process. And the surgical masks are really, they're fluid resistant. They provide the wearer some protection against really large droplets or splashes, and also protects the patient, if a healthcare is wearing it, from respiratory coming from a physician to the patient. But while the N95 also reduces exposure to particles and certainly large droplets, as well as a large percentage of aerosolize. So a lot of air is actually blocked by the N95s. Well, really, the surgical masks don't really protect from aerosolized particles going back and forth. The N95s are tightly fit. They have a really tight seal. Maybe not as tight as your friend's goggles, but a very tight seal. But the surgical masks will have leakage around them. Both of them were designed to be disposable. At least, certainly the surgical mask was being disposed, and while the N95 was what should have been discarded after it was being used. So there are some similarities. But if you really think about it, one is a really tight mask that really almost more like you think if you're doing scuba diving, while the other is much more a way to really protect fluids going back and forth. Now, the lay population in the public walking around, I think the idea is that we do think that higher amounts of viral load, higher amounts of virus getting into a person or patient may make someone more ill. So by any sort of blockage, that may protect patients from either not getting sick or not getting as sick at all. And so I think we're in a situation where we're obviously in a very critical time. We're looking for any little benefit, and that's why the idea that wearing masks may provide some benefit from people walking around. But they're certainly not the mask that one would use if you were in a healthcare situation.
Sure. And Dr. Dahut, I know that the CDC is now saying, to wear these masks, homemade masks when you're out and about to try to slow down the spread. And many states, most states, now have these stay-at-home orders in place. What is your feeling, or what are you seeing as a doctor and a scientist about the results in terms of these stay-at-home orders? I know there's obviously mixed compliance, but do we have a sense? Are these orders starting to work? Is it important that we continue strictly with these orders for now? Tell us what you're seeing in that sort of public health conversation.
So, I'm not a public health expert. So I think that's important that I would defer to someone like Dr. Fauci, who we're obviously very proud of. But from a scientific perspective, if you have a virus that can be spread only by person-to-person contact or likely by a person leaving a mark somewhere, the virus somewhere, if you can stop that spread, it has to decrease the ability of the virus to disseminate through the population and cause illness and death. So we know there's a lag period. We know a couple things. We know there's more testing being done now, so we are going to find more patients who have been infected, and we know it takes a period of time, sometime between 3 to 14, 12, 13 days for someone to get symptoms. And then if someone gets very ill, it can be weeks after that while they're being treated. So if we start trying to look at the number of diagnoses and the number of patients who are dying from the disease and try to make a determination today about the efficacy of social distancing, it's actually still too early and still impossible. But I certainly think, looking at experiences in other countries, it seems when that's been put into place, it has had an impact. And so I think it's right now, it's certainly the simplest thing we can do, and it's probably the most effective.
Got it. Dr. Dahut, and I appreciate you mentioning Dr. Fauci. I think that we all have great and high regard and gratitude for Dr. Fauci, Dr. Birx, all of those public servants who are working around the clock to confront this pandemic. I come from the world of HIV and AIDS in the 90s, so I know Dr. Fauci's work quite well, and we again are so I think so lucky to have such great public servants who are leading our charge here. Dr. Markham, we know, like some cancers, there's currently no cure for COVID-19. How are patients being treated? Are ventilators, I know there's a lot of talk about ventilators. Are they an important form of treatment for this? What other treatments do we see that are either experimental or being studied right now?
Sure. So I think one of the really exciting things that I've seen since we've been dealing with COVID is the collaboration that's happening between scientists and researchers really globally, because we do want a cure, and we want more than a cure. We want a vaccine. We want to be able to prevent it. And the scientific community has really come together on this particular issue quickly, and it's actually been one of the very encouraging things that I've seen, and it does give me hope. So there are things that are being done for patients who have COVID, and I think what I'll start by is saying that actually not everybody needs active treatment for it. So many people actually may have the virus and have mild symptoms, and I think that's what we would hope to have if we were to develop the virus is just mild symptoms. So cough, maybe some mild shortness of breath, fever, nausea, diarrhea, those kinds of things can happen. There's some evidence also that some people may actually lose sense of smell or taste, and that could be a symptom. But for people who need to be treated more aggressively, so for people who have more severe disease, meaning more shortness of breath, such that they really can't go without oxygen, I think having hospitalization capacity, being able to be in the hospital for treatment is really important. And this is where the roles of ventilators come in. So someone with a really severe form of COVID-19 may develop something like a pneumonia from it, and their lungs just may not work well enough to be able to breathe for the patient. And so it's very important to have the ability to use a ventilator to help breathe for that patient while they recover from the virus. There are things that are being looked at in clinical trials and research studies. One of them is using plasma from people who have recovered from a coronavirus infection. That plasma may have antibodies that can help fight the infection. And so it's currently being studied as a potential treatment. There are some drugs that are being investigated as well. Actually, there's a variety of clinical trials out there. We talk about clinical trials in cancer quite a bit. Cancer clinical trials are crucial. It's the only way we make progress towards finding a cure for cancer. The same thing holds true right now for COVID-19. So if one of your listeners happens to become ill or knows someone who becomes ill, the opportunity to participate in a clinical trial is really what's going to move us closer to a treatment, a cure, and ultimately a vaccine.
Excellent advice and a good plug for participating in clinical trials, and we are big supporters of that, Dr. Markham, so I appreciate that. Let's stick with this clinical research piece, Dr. Dahut, for a minute. Dr. Markham mentioned that we're looking at testing certain existing medications in trials, that we're starting to see some companies green-lighted to begin trials. Dr. Dahut, can you talk? And we're also hearing about the possibility of trials going at sort of record speed. Can you talk to us a little bit about, Dr. Dahut, about how clinical trials in the circumstances are the same or different from the normal process? Are we going to see things, accelerated? And I'm just curious what you're seeing on the clinical research side here.
Sure. Let me talk about a couple things on that aspect. First of all, I think it's important to know that for patients that are currently on cancer clinical trials, which I'm sure a lot of your listeners are, there's really been increased flexibility looking at the IRB and the sponsors, allowing patients oftentimes to get treatments closer to home and sometimes to modify their treatments. Again, you'll need to work through with your IRB and the sponsors of the treatment, as well as obviously your treatment centers. But I think there's really been an understanding that what needs to be done is to maximize the benefit for the patients and protect their safety. And really, what we're seeing is a lot of tests that were often done on clinical trials that were much more for long-term benefit but would put some short-term risk for patients if they had to come in for blood draws, for example. We're actually deferring at this point. And every action we're doing now is looked at a short-term risk-benefit for the patient. So I think folks on clinical trials, if possible, try to stay on the trials, but there may be modifications. Now, as far as, you're exactly right, as far as getting new drugs into patients, IRBs, pharmaceutical companies, academic centers, and others are working at breakneck speeds to get drugs and treatments into patients as quickly as they can. I'm aware of a couple of potential new therapeutic trials that actually agents that may be coming from the cancer background, that where trials are being written under team efforts, they're being reviewed by the IRB, immediately, and communications with the sponsors are being done very rapidly. So I think your listeners should know that everything is done possible to sort of break through any bureaucratic barriers to get potentially life-improving treatments into patients.
It's good to hear, and I certainly hope that our ability to do this and to collaborate and to accelerate the speed of some of this research will be a benefit to us down the line, in oncology as we look at trials and other collaborations into the future. Maybe we're creating some models here that will have some application, well into the future. Dr. Dahut, this is another question we're getting. People are there's so much out of people's control right now, and it's contributing to a lot of fear, a lot of anxiety, and we know that even, for example, when folks are diagnosed with cancer, they're looking for some ways to take back some control. And what are some of the things that they can be doing? Aside from the protocols that we've mentioned from the CDC, are there other things that people can be doing to support a healthy immune system? Are we looking at, making sure you have a good balanced diet, keeping those processed carbs and meat and sugar out of the diet? Are we looking at getting a good night's rest every night? What are some of the things that folks can do to have some control and maybe invest a little bit in the boosting of the immune system?
So I think this is something that, we get asked all the time. I think it's very important, for cancer patients to have control over what they can control, to fight their cancer. I wish there was a magic bullet in order that one could take a simple pill and that would simply protect one and improve their ability to have their immune system function. But again, this becomes a personalized decision, a personalized roadmap if possible. So if patients have an underlying medical problem, this is the time when possible to control it as much as one can so they're as healthy as possible. So if you're a cancer patient who has diabetes or high blood pressure, or if you're a smoker, these are the times to stop the smoking, to work to get your diabetes under control, to do what's best to have the strongest possible cardiac function, because you need to be in the best possible shape that you can be on every aspect, not simply your cancer if you were to fight this infection. The immune system is a very complicated thing, and some aspects of the side effects from this infection, in fact, the patients who have gotten particularly ill, appears to be actually a very active immune response. And so we're always trying to balance at what point do you need a stronger immune response, and what time, as we do in some cancer patients, we actually want to suppress the immune response. So, as we learn more about how best to treat patients with the COVID-19 infection, I think we'll have better guidance. At this point, I think doing what can keep you overall as healthy as possible, good night's sleep, taking a good walk, and managing your other medical problems puts you in the best possible position.
Terrific. Well, we are getting towards the end of our show. So, I'd like to hear just a little bit from both of you. I'm going to start with you, Dr. Markham. We certainly are living through a historic period now, and I'd be curious just to get your sort of reflections at the moment on what it's like to be a doctor, an oncologist working directly with cancer patients during this time. How has it impacted your work? You've certainly had to, I'm sure, pivot with a lot of your patients, engage in that shared decision making and that important patient-physician communication. But I'd love for just Dr. Markham a moment to share about what this has been like for you, and also to you, Dr. Dahut. I'll ask the same question.
Oh, boy, it is a really interesting time to be living and working through. I think, oncologists are always very well aware of how immune compromised their patients are, and the special precautions that we need to guide, counsel them on and pay attention to ourselves. And this really has just highlighted the importance of that. I think it's been a very interesting experience counseling different patients through their unique experience. And it's more than just what cancer they have and what treatment they're on, but it's, who do they live with? Do they live alone? Are they the primary caregiver for their, 89-year-old parent with dementia who they are the full-time caretaker for? So every issue that is really important in the cancer experience is magnified right now. So that's been a challenge, but it's been a good thing to figure out how to deal with. And also, like many doctors, I've learned to embrace technology, and telemedicine is a very new thing for me, but I'm learning how to make it work, and my patients are learning how to make it work, and so we are learning together. I lead a division of about 100 people, including oncologists and fellows and nurse practitioners and physician assistants and staff members. And another thing that has been weighing heavily on my mind is how not just to keep my patients protected, but how to keep my colleagues protected and how to support each other. It's a really interesting time, and I am grateful, though, to be living in this community of healthcare professionals who really do support one another, and we all have the patient's interest at heart and each other's interest at heart, and I think it's magnified now.
Yeah. Good comments. I'm going to finish up with you, Dr. Dahut. We have a minute or two left. What are your thoughts, reflections here?
No, I think everything that Dr. Markham said, I would certainly continue to emphasize. We never stop worrying about the safety of our patients, our staff, and actually, of course, our families and friends. And we have become more creative. I've really been inspired about the way our teams have worked to come up with ways to really minimize the contact that we have between the numbers of providers and our patients in a way I think are still providing, excellent care and fulfilling all our regulatory requirements. So I think the creativity that's come up there is really striking. So, I think one thing I did want to say is, this is really a frightening time, I understand, for cancer patients. Cancer is a terrifying disease, and perhaps even more terrifying during this pandemic. And I think it's important that your listeners know, even though, we're not in our laboratories, we're physically distanced, we still spend a lot of time thinking about what we can do to improve the outlook for cancer patients. We are still thinking about future clinical trials, how to treat patients, how to improve patients' quality of life and how long they live. So, even though a lot of our time is focused on this horrible pandemic, I think it's important that your listeners really understand that we are still doing everything we can to improve the outcome for cancer patients.
Well, that's very reassuring to hear, Dr. Dahut, and I know our listeners will be happy to hear that from you and reflections from both of you. I want to thank both of you for joining the show today. This has been a very helpful conversation for our listeners, and I also want to thank you for all that you're doing to care for cancer patients, to take care of each other as colleagues, those around you, to keep everyone safe, and we are in this together, and I know we're all hopeful that we'll be together on the other side of this. I just also want to remind our listeners that we have a host of free services for you at the Cancer Support Community. If you're facing any kind of cancer diagnosis at any stage of illness. We also have support services for the loved ones and caregivers of people with cancer. You can call us on our helpline, which is now open 7 days a week due to the coronavirus epidemic. We're getting a lot of calls on the helpline. If you're feeling isolated, if you're feeling lonely, you want to connect with one of our counselors, you want information, give us a call, grab a pen. That number is 888-793-9355. Again, it's 888-793-9355. We also have, we've created a whole coronavirus section of our website. So if you go to cancersupportcommunity.org/coronavirus, you'll find up-to-date information. We're updating that daily for cancer patients. We also have a wonderful online community called My Lifeline, where you can set up your own online platform where you can invite your friends and family in, and you can share what's going on with you through video, through photos, through a helping calendar. If you visit us at My Lifeline, we also have discussion boards. We have thousands of folks in our discussion boards and a lot of chatter, as you can imagine, on those boards right now about COVID-19. So we are here to support you through this and beyond. So give us a call at 888-793-9355. I'm Kim Thibodeau from the Cancer Support Community. This is Frankly Speaking About Cancer. Until next time, be well, do well, live well.
Thank you for joining us for Frankly Speaking About Cancer with your host, Kim Thibodeau. We're here for you every Tuesday afternoon at 1 p.m. Pacific Time and 4 p.m. Eastern Time on the Voice America Health and Wellness Network. In the meantime, stay connected online at cancersupportcommunity.org. That's cancersupportcommunity.org.